So thank you all for your excellent talks. I had a question for Dr. Wolf about the rebound headache because I find it difficult to decide when to start treatments and if there's a specific population who's at risk for rebound headache. We had several cases where they had papilla edema and even some visual decrease, and I find it difficult to find who's most at risk for this.
I think we probably should have a survey, just how we all do it. I've heard about different approaches. I can just tell you how we do it. So many patients have a slight rebound hypertension, and we tell, okay, that's good. Now we are going, and now that's the start of you healing. And most of them are fine within the next few days. So usually we don't treat them as in the first place. If they were symptomatic array, like they cannot sleep and they cannot really like handle the symptoms, and then we start with the cetazolomide, and usually we can taper this up in a few days. I actually am surprised. I have very few cases with papilla edema, and all of them were IIH types. So I think that's probably something, again, we need to look into it. And with some patients, I think like in the first place, we thought, okay, they might have come from IAH. Then we tend to treat earlier and follow up. And also, I would also like to hear some of your opinions, and we try to get them as soon as possible on GLP-1 receptor agonist, because it also has some effect on the blood-brain barrier to reduce CSF production, and it reduces the weight. So to prevent for like going back and forth between the CSF loss and hypertension. So that's something we try to do, but we are sometimes like it's very difficult with our insurances. I would really like to hear your opinion from your centers. I guess probably everybody has their own.
I can't say that the patients I see recover as quickly as your patients do. Um, and even when you look at the literature, most of them do not have papilledema, but some do. And I've seen it happen recently in a person who had absolutely no risk factors for having IIH before. Um, so I will generally use acetazolamide. I found that it is not tolerated very well by a lot of people, in which case I will either switch to methazolamide or I may even try topiramate because it probably works better for the headaches as well as lowering CSF pressure. Um, Studies actually indicate that topiramate may be more effective than acetazolamide in lowering CSF pressure. And since I'm a neuro-ophthalmologist, I can also follow the visual function, which is convenient for the patient, I guess. The only study that I know of which looked at predictive factors is from Vouter. Yeah?
Well, I mean, that's
Looking at
one
MRIs,
thing
the
I've
pre-op, the
been
pre-treat, the pre whatever procedure MRI, that you found that a lot of these people that got rebound intracranial hypertension had signs of elevated CSF pressure on their brain MRI. Was that you?
basically what we looked at in a group of patients. We looked at their pre-op. Most of them had surgery for their leg. We looked at their MRI venogram, and the patients who had bilateral transverse sinus stenosis were at much higher risk than any other type of patient. So it wasn't so much the duration of the leak, it wasn't so much the type of the leak, but this was done like quite a few years ago, so we didn't have that many fistula patients. But it mostly seemed to depend on whether or not there was a pre-existing transverse sinus stenosis.
I have a two-part question. The first is for any of the surgeons, when you're operating on ventral leaks, how often, because I don't think it's published, do you think you have visible xanthochromia at the time of surgery?
10%, just an estimate.
Just an estimate. Um, and then the second follow-up to that is in brain sag dementia, do you often see superficial siderosis? Because I don't think that's been published that either.
Well, patients who have, really severe brain sagging with frontotemporal dementia type symptoms, none of them had superficial siderosis. But again, like of the, I think we've seen maybe 70 now, 70. Only one of them had a ventral leak.
Right.
Half of them, we never were able to find a leak on them. So maybe there was a different reason for their lack of spinal CSF.
Thank you.
I have a question from our virtual audience. I would like to ask Dr. Jürgen Beck to comment on the role of CSF ferritin in superficial siderosis in SIH.
Little is known. It's could be a marker of siderosis that is about to come. Probably we should look at this more often because, as I tried to mention during my talk, once we see full-blown siderosis, it's too late. There's a lot of damage that already happened. So probably we should just measure ferritin each time we withdraw CSF. We don't do it, we are sloppy, but probably we should do it, and we should clearly put more research in biomarkers for SIH and also for superficial siderosis. So I think it's a good question, and we should be doing our homework better.
Unfortunately, in the US, in both the West Coast and the East Coast, it's impossible to measure ferritin in CSF. But in Europe, apparently, it's pretty easily done.
It's not easily done. It was a project in Bern, but it's doable.
And then there was a follow-up question for you, Dr. Beck, from the same individual. Is there any role for routine usage in current practice, measuring ferritin? Or is this just an obvious curiosity
Usage of what?
to measure ferritin?
Again, say it's a single study. There is no scientific evidence to do it. But again, I would clearly encourage to do more biomarker research, and not only for superficial siderosis, also for spinal leaks per se. And when we touch the topic of postural puncture headache tomorrow, even in this disease, we do not really know whether it's all a fluid, a physical fluid thing, whether it's all low pressure, low volume. We discussed this a lot. And we get to know more and more data that the volume is probably normal, that the pressure is probably normal. So what about that at least part of SIH and part of chronic postural puncture headache is a metabolic syndrome, is something is deranged in the functioning of all the transmitters, of all the toxins in the brain. Now we have iron because it's so easily visible, but what's with all the other stuff? I think we should do proteomic studies. We should do single cell sequencing of the glial cells. We should do single cell sequencing of the inflammatory cells in the CSF. We don't do that. So we don't know. I don't have an answer to this question, but I strongly believe in, because this is such a multifaceted disease, that we should not ignore this side of the spectrum.
I have a question. I also wanted to make a comment on Dr. Beck's comments just now. My question was about retrograde flow across the fistula, as you mentioned in CVF, possibly causing superficial siderosis. There's been one documented case of retrograde flow across CSF lymphatic fistula. And as a CSF lymphatic fistula patient, I clinically experienced that and treat it in response to the theory, but isn't currently in a peer-reviewed paper. My question is, should we also be looking for lymphatic biomarkers in CSF, as you suggest, looking for ferritin in CSF? And what might be the long-term complications similar to superficial siderosis in patients who have CSF lymphatic fistula with retrograde flow? I know that's another curly question. Apology. The other thing where you're talking about biomarkers for disease and deranged metabolic conditions, one of the things I'm considering.
The question is excellent. I'm just not able to answer it sufficiently. Probably you, Marcus, or anyone has an idea. Katharina, right, neurologist?
Not for lymphatics, but and it's just not my idea. This same as Dr. Andrew White. He did his neuroradiology fellowship at UT Southwestern, and he was wondering if beta 2 transferase in the serum could be a marker for CSF venous fistulas. I thought that was a pretty cool idea. We measured it in one patient. We only had N of one. It was kind of a hassle. We had to send the blood somewhere where they could do it. And it came out negative, and I don't know if that was just a fact that there's not enough to measure when it gets circulated throughout the entire system. But I thought it was pretty intriguing.
One of sorry, one of the curious things I've noticed is that 56% of patients with a diagnosis of ME, chronic fatigue, have brain sag visible on their MRI imagery. And I'm considering whether possibly they are a missing group of CSF leakers, and potentially are some of them leaking into the lymphatic system, because as a CSF lymphatic fistula leaker, headache is not the primary symptom, fatigue is quite noticeable as a symptom. So perhaps that's a group of patients we're missing. There is a lot of research in the ME CFS space about other potential biomarkers. So if there is a crossover of a patient group, is there an existing body of research that we could tap into for these potential markers? They're looking at mitochondrial dysfunction and other potential markers that way. I think I can just continue that. Currently, we don't know, but I think what we can pick up of this is not just the CSF lymphatic drainage, which now occurred to access via the nasal mucosa, and that we get this lymphatic drive that we still need to investigate and see how that is regulated, which we will hear talk of by Horst Oberth tomorrow about lymphatics, and all we know about the regulations from the mygonadogout group. So I think that's also something we need to keep in mind and connect this. And also, I hope for somebody getting down with a mouse model or something with a spinal model, and to look into how the lymphatic drain and the venous drain looks like there. And I think we're still baby steps. We're talking about huge science. And something we still don't understand. So just aligning a few things would probably help us to get maybe one or two ideas. Since I have the mic,
All right. I have another virtual.
could I ask you something?
I'm sorry.
What?
I really would love if you help me to understand why the craniotomy or the defect in the head skull causes brain sag.
I mean, I don't really know why that happens, but there's this entity called the sinking scalp syndrome, right? Patients who have a craniectomy, but prior to a cranioplasty, because we generally like to wait before we put the bone back. That can cause symptoms, right? Usually not orthostatic headaches, but it can cause headaches, fatigue, things like that. But there have been quite a few cases described where that's much, much worse after doing a lumbar puncture for whatever reason. Let's say, the wound isn't healing so well, somebody gets an LP to rule out meningitis, and their headache becomes really bad, or they become comatose. So we know that, if there's a gradient between atmospheric pressure and intrathecal pressure, that can be a cause of brain sagging. So I think that might have something to do with it. They're very
Waiting for the
thoughtful.
model to show up in your next paper.
I think Dr. Beck is working on that. All right, and I have another audience question also for Dr. Beck. It says, have you experienced a patient developing superficial siderosis in the year following ventral spinal CSF leak surgical repair?
No, I personally haven't, but there is a report from Cedars that at least a couple of patients develop it early, if I read your paper right. I'm not aware of that it continues after surgery. Then I would suspect that the leak hasn't been sufficiently closed. But this is also speculative, and we don't really have large numbers. Usually, at the rule of thumb, it takes time. There are exceptions that after 1 year, or even after, I think there was one patient in your paper, after a couple of weeks, there's superficial siderosis. But as a rule of thumb, the longer, the higher the risk of superficial siderosis. And once the leak is sealed, it should at least stop. Hopefully, it gets a little bit better.
Yeah, I think this was more about the situation where you have a patient who does not have superficial siderosis. You repair the leak is repaired, what is the risk of developing superficial siderosis after fixing the leak, thinking that, all those years, I guess, that the person has been leaking, might it be like a delayed radiographic appearance of superficial siderosis?
Good reasoning. I don't have a case. I don't know. Good reasoning.
I've noticed in many of my myelograms, maybe 20 or even 30% of patients investigated for CSF leaks, that they have ossification of the ligamentum flavum in, patches through the thoracic spine principally. Has anyone else noticed that, and what does it mean?
Horst?
Did you ask Dr. Urbach? Did you ask Horst? Is that what you said?
Horst? I have no clue. I don't know. I don't know. No, I haven't looked at it. Niklas, tell something. This is a radiological question.
To be honest, I haven't looked at this too. I mean, sometimes in the dorsolateral leaks, we have the big facet joint who probably makes a leak. But calcification on the ligament, I never really looked at this in detail.
So to give you an answer, if you force me to, this I have not observed during surgery that the ligament there was ossification. No. Okay.
Let's ask your neurosurgeon what he thinks.
When we went through a phase of wondering whether that might cause a dual tear, and we did explore a couple and did not find them. So I've not seen. But we see the calcification. Yeah, but I guess it'll be fair to say we've reduced our emphasis on the likelihood that it's related.
So I have a question about airplane flights. A lot of patients ask if they can fly after their leak is sealed or with an active leak, and the evidence is scarce and somewhat contradictory. I know of the study of the Danish Headache Center that published a case series of some SIH patients that worsened or first experienced symptoms after airplane flights, but I've seen myself many patients who have been flying with active leaks with no problems whatsoever. So I really don't discourage it, but I'm interested to hear your opinion on this.
I generally encourage patients to fly to wherever they need to go to for a leak, right, rather than driving 12 hours. And we've never published that. Once did a survey. I don't remember how many patients, 30 or 40. And I think 70%, there was no change in their symptoms. But taking into account, that they would not be sitting, they'd be flying, either first class, business class, or they would take a red eye and could just, lay in a couple of seats. About 20% felt actually better during the flight and 10% felt worse, right? So except people who, might fly out on a private little jet, all commercial airliners are pressurized to at least 8,000 feet. The Boeing Dreamliner to 3,000 feet. So yeah, generally that's not an issue.
I have the
I
same experience. It's one of the questions I ask my patients when I'm thinking about whether or not they have a leak is how do you feel in the airplane? And in general, I find that patients who have SIH feel either just as good or just as bad when they're on the airplane, or better. Most of them I find they get better on the airplane. Conversely, patients who have IIH feel worse at altitude. The other thing that SIH patients tell me is they feel better in the swimming pool. So I asked that one too.
Uh, can I ask you? Thank you. I'm Vittorio Civelli. I'm an interventional neuroradiologist. I work in Paris. And It's a question about pathophysiology. And I was in one of our conference several months ago, and there was Nick Ingis. Nick Ingis is an interventional neuroradiologist, the first one who put a stent in the venous sinus to treat IIH. And he pointed out that there are several clinical situations that share several common features, like chronic fatigue, IAH, SIH, or normal pressure hydrocephalus, and he tried to, and he pointed out that, and there are several now case reports that found there's a common feature that's the stenosis, this venous stenosis in the cervical region. And he advanced an hypothesis so that can unify almost some cases where this venous stenosis, both in the dural sinus, but also in the cervical region, in the presence of this stenosis, we can have different clinical situation according to compensation processes. So you can have a skull-base leak, and you can have a normal hydrocephalus but symptomatic for spontaneous CSF, or you can have a leak at the spinal level. So you can have an SIH, or you can have other patient that doesn't compensate with lymphatic or lymphatic system, and then develop a clinical IIH. And the common point is this venous stenosis. And there are some case reports now that, for example, there's a spontaneous spinal leak that was treated by a stent, or I don't remember if a stent in the jugular, or they decompress the bone impression on the venous, and the hypertension just went away, the clinical situation, or patient with chronic fatigue that just was in bed for several months. They stented the vein, and the patient just healed. So can you comment on that? Do you think it's a valid hypothesis? Is something we can look into, or not?
Right. So look, I think it's perfectly reasonable to connect intracranial venous stenosis with impaired CSF absorption, leading to increased intracranial pressure that then manifests either as IIH or increases the propensity for developing a CSF leak. So I think treating intracranial stenosis in that setting is perfectly reasonable. But I would emphasize that it's really the intracranial pressure that's the problem. It's not the venous flow itself. It's only if it causes a pressure problem. The difficulty I have with the extracranial, so cervical venous stenosis, is that in the normal situation, how the venous outflow from the brain goes through the internal jugular veins when we are supine. When we are erect, the jugular veins collapse because they're actually under negative pressure, and the venous outflow is actually through the spinal epidural veins. It's not actually through the jugular. And so I have difficulty connecting a jugular venous stenosis with the same pathophysiology as intracranial venous sinus stenosis, unless it is demonstrated that there is an impact on intracranial pressure. Now, all of these patients, you find that there's a lot of, when they do have an extracranial venous sinus stenosis, there are a lot of collaterals that develop. You see that on MR sonography. But a lot of patients come to us saying, look, I'm symptomatic from this, and they think that it's the blood flow that's the problem. But I'm still of the view that it can only be a problem if it affects intracranial pressure. So if you measure intracranial pressure and it's normal, then the venous stenosis in the neck is not problematic, unless it has caused intracranial hypertension and a CSF leak in the past, which is pretty uncommon. That's my opinion.
Thank you very much. I just wanted to highlight a patient I had recently who had superficial siderosis infratentorial. And, as we know, we expected neuropathy. And to my surprise, when I did the myelogram, I actually saw CSF venous fistulas. And then I had the same problem with Dr. Beck is reading your paper. I just wish it was in tabulated form, Dr. Sheevink there. No, I'm just joking. But But my question is, what was your experience with those 5 patients with the CSF venous fistulas with siderosis? Did they get much better? What was your ultimate hypothesis in the end? Was it leaking back from the fistula, or was there some other neuropathy? I wonder if I should be looking for something else in those patients.
No, I think there's pretty good evidence that, that can be bidirectional flow through a CSF venous fistula. Um, it was pretty straightforward to say, that their leak was gone. And I don't remember exactly, but either 2 or 3 out of those 5 patients also had other MRI features of SAH, and that went away after surgery. None of those patients had other SIH symptoms. So the other ones we've just been following with serial MRIs. But it's a little bit difficult, right? Particularly the patient with a really high hemosiderin load on their MRI. I mean, it probably can get 10 times worse before we would see it on an MRI scan. And of course, we would follow their symptoms of superficial siderosis. Which brings me to our next question from the virtual audience, and I think I will ask Dr. Wolf, um, which should be the endpoint to treatment success? Only clinical and whole CNS MRI might not be enough, especially in oligosymptomatic patients. For instance, residual intermittent auditory symptoms, no headache.
Absolutely agreed. I would yet say that in this disease, we have a kind of like a ground truth that there's an open leak and a closed leak. And I think we always should make sure that this is the case. And in the long run, it's like all of our data shows that there is something that changes in between. I think there's the complexity of the system. It's like defining a syndrome and working from there. I think we are now in these days, we have so many more options. We really need to go into biomarkers as well. We need to take um, quality of life measures, symptom measures. Like all want to end up helping the patient finally healing and getting better. But endpoints chosen at this time that just marker the clinical outcome, I think that draws us back. We have this perfect disease actually in a research way. And we really need to look into biomarkers, measurements, and try and understand and possibly even get better in other diseases, spread out, translate this to other headache disorders. Why is migraine reacts to changes in pressures and so on? Can you tell by the weather that migraine starts? So I think we should come up with more questions and not like try and confine things. What do you think?
Well, actually, I was going to ask Dr. Beck what he does on his patients with superficial siderosis. Let's say they have a ventral leak. You repair the leak. The post-op MRI shows the leak is gone. Symptoms remain the same. Do you do post-operative CSF analysis after a period of time to show that the red cell count is low, xanthochromia has resolved?
Unfortunately not. No. We do surveillance together with neurology, only clinical and imaging based, not based on blood or CSF biomarkers.
I have not wanting to dominate microphone time, but just to touch base on the barometric pressure question, particularly about flying, but also atmospheric pressure and the impact on patients with CSF leak. I've been monitoring barometric pressure change every 2 minutes for the last 18 months, and its influence on my symptoms. And initially, the data was showing that it wasn't an absolute measure of barometric pressure, and it wasn't particularly high pressure or low pressure that impacted it. It was the rate of change. So if the barometric pressure changed more than 0.8 of a hectopascal per hour, it would instigate an acute neurological event related to my symptoms. Conservatively managing connective tissue integrity has improved that to the point where I now only have an acute neurological event with barometric pressure change of 2 hectopascals per hour, which happens less frequently. So I have fewer acute neurological events. I'm in discussions with other patients about
barometric impacts on their particular symptoms. They notice it as well driving in mountains, for example. You'll find patients that can't handle being in a car. I'm particularly interested in talking to doctors and patients about creating collaborative research projects where we can ask the right questions, collect the right data, and find ways of understanding this particular aspect of this particular disease. But I'm not sure whether anybody else here has any suggestions for how to fund this research or plan this research or do this research and how we can collaborate and start understanding these bits better.
I'll second the observation with my daughters were patients. A change in barometric pressure seems to affect their symptoms more than any absolute pressure.
That's not unique to SIH or IIH. I mean, it happens with migraine as well.
I hear what you're saying.
There's a crossover of misdiagnosis. I was misdiagnosed with severe constant migraine with neurological manifestations when it was CSF leak. So a lot of the things that are understood, a lot of the problems I'm finding in the epistemology of these conditions is how do we define what the condition is, how do we diagnose them, and how do we deal with separating people into the diagnostic boxes. So I think there's a lot of confusion across this. Sorry, that's my alarm.
I think Dr. Rao has a question over there. Needs a microphone. No, you do. Everybody needs a microphone. No, you're good?
I have a question to Wouter and to Nicholas Litzen. These lateral tiny little leaks, do you think Nicholas would have found it with ultra high beam, cone beam resolution CT as fistulas? And second, are they all better? So after 27 patients is a lot. After you closed them, the SIH was gone?
That's a really good question. So, about 40% of those patients had a normal brain MRI, which is quite a bit higher than, the average patient with a CSF leak. And the resolution of symptoms was less frequent than what we see in, patients with a more obvious leak. I do think that a dynamic CT myelogram would have shown that. As a matter of fact, there were 4 people that we operated on who also had a dynamic CT myelogram done at another institution, and you could see it on their myelogram too. On our myelogram, right, so we do a digital myelogram. We pay a lot of attention to that. Then they go to the CT scanner, just supine. And we only saw it on our post-myelo CT, like 2 out of those 31 patients.
One question to that. You said you haven't seen them drain into the veins, these small, tiny leaks we are talking about. What do you think why this happens? Why do we not see them draining into the veins when they are CSF-venous fistulas?
Yeah, I mean, I don't have a perfect answer for that either, but it certainly looks like part of it has to do with the volume of the leak, right? They seem to be smaller veins. Um, Obviously, you don't see the vein on the digital subtraction myelogram. So I do think there's a relationship between the volume of the leak and what we see on a scan, or how severe the symptoms are, or how obvious the brain MRI is affected by it. And then sometimes, we think, boy, maybe it's like a physiologic CSF venous fistula. That's possible, right? But when we've done studies on other patients with, for example, normal brain MRIs, but just orthostatic headaches, we don't usually see that.
These are super interesting observations, Wouter. Also, these tiny little leaks. And maybe, if I remember correctly, these very nice images done by Marcel are done under general anesthesia. So you have positive pressure airway ventilation. This could be one explanation. This is why I was asking, because you are doing the CT myelograms, the ultra high resolution cone beams with spontaneous respiration. And this is the same what I mentioned. Why do you see a vessel-like, heartbeat-like flow of contrast into the vein? And during surgery with positive airway respiration, patient lying on the belly, it's tough to see. It's a huge difference. And maybe this tiny little findings you nicely as shown in your latest submission could be visible in spontaneous respiration. And then there is the topic, what's physiological? This is so super interesting. We'll see. Very good observations.
Okay. I have one more question. I would like to come back to the CSF-venous fistula and the associated siderosis. Can you please explain why do you think we have good evidence that the flow is going in both directions? There's a new publication from Ian Mark who was looking at 100 patients after embolization, and onyx never migrated into the intrathecal space. So this would be a good argument to say it's only going, the flow is only going in one way and not into the other way.
Yeah, I don't think that's a very good argument because I don't know if you've ever seen post-embolization scans from the Mayo Clinic in Rochester. They're really, really conservative. No, I'm kidding. They inject an enormous amount of onyx, but I mean, onyx basically is rubber. It's not a liquid. So I think it's just a different, just a totally different situation.
But it's interesting because when you go with the microtheta to this place, you sometimes have high pressure when you inject onyx and then do another contrast injection. This is sometimes high pressure. So I would expect if there's a two-directional way, I would expect to see it going into the intrathecal sac. So what is your argument to say that we have good indications that it is flowing in both directions?
Well, because they develop superficial siderosis, right? The longer these CSF venous fistulas are present, the higher the frequency is of finding superficial siderosis. And obviously, when you cut the vein, it usually bleeds pretty profusely.
Just going back to the case that I had, my superficial siderosis case, going back to what Nicholas was saying is, with that case, I was curious to see if the onyx would go intrathecally, and I was very thorough, extremely tons of onyx, and I have not seen a case yet where the onyx will go intrathecal. Injecting contrast, it doesn't go intrathecal now after almost 100 cases, so that's why I was just curious to see what that you see in the surgery. Maybe there's something else going on. But yeah, it's very curious. I mean, also use the thin onyx. We have two different preparations of onyx, 18 and 34. I use the thin one to make sure it penetrated thoroughly and it doesn't go intrathecal. So I think like in Ian's paper, there's certainly a valve phenomenon there. Why that is, I don't know 100%, but
And even more, sometimes we also use a balloon, right?
Oh yeah,
so
each one of mine I'm extremely
so we put a lot of pressure while we are injecting. So I don't know.
I'd just like to point out that CSF drainage into the venous system in the spine is normal, as it is into lymphatics. It's part of the normal absorption process of CSF. Just the same as in the head, there are arachnoid villi that we think are the main pathway for CSF to get into the intracranial venous sinuses. Those structures are around spinal nerve roots. And probably, I mean, we don't know, but they may well be the basis for anatomical formation of a fistula. So whatever the valvular mechanism that's underpinning that normal process is probably still there to some degree for most cases, which would explain whatever that valvular mechanism is, and that's controversial, but whatever it is, that is probably explains why it is a one-way flow. But there would be circumstances where that valvular mechanism would be overwhelmed and then blood could come back through. Right. But that's the minority of cases, isn't it?
We cut out several veins, CSF-venous fistulas, send them to pathology, and found no valves. So we found no mechanical obstruction of any flow back and forth.
Just wanted to mention our observation about flow in CSF-venous specifically, and it is incredibly intermittent in our experience. We can do a DSA myelogram, and what we do is we proceed straight to high resolution cone beam CT while the patient's on the table. And if you do it quickly, you will see the paraspinal vein opacified. And if you delay or try to complete the DSM study before going to the cone beam study, you may miss it. So that the flow of these things is just so incredibly intermittent, and when it feels like it.
Maybe one argument for the both wave flows, it might be that it is at the time you pressurize the vein, it may collapse, same as the jugular vein, and just cause a collapsing resistance. And that's why it doesn't transduce into the CSF space. That's just one thought. The other thought, I think, hadn't been discussed. That it might be also the hypermobility within the intrathecal space causing microbleeding. I think that was not an idea I think I've heard it before, but probably Marcus can tell us whether this is true or not, because do you see siderosis in any caries? I think I've heard the argument before that the siderosis might be caused by the hypermobility of the brain within the intrathecal space, which we know occurs in SOH and in caries, so causing microbleeds because of some mechanic stress to the suprarachnoid, small vessels. But the main argument could be your observation from many, many caries who show exceedingly high hindbrain motion. And so my question to you is, have you ever seen siderosis in those? Because that would be the argument, is that it's not within.
Answer was not one.
It's a great question. I've never seen.
I just wanted to say that there's some the original research from I think the 70s and 80s on CSF resorption and spinal nerve root arachnoid granulations is through vesicular transport. So it's not a mechanical bulk flow valvular type mechanism. It's vesicles.
Yeah, I skirted around that. Because it's probably that at least in the head, it's a transcellular flow, and it's probably not just vesicular, but the channel opens up the whole way through the cell. So it's not a pinocyte that goes through the cell and opens up on the other side. It's the channel that opens up through the whole cell, and CSF goes directly through.
I've got a question just been touched on already, but how sure are we that the bleeding in superficial siderosis is coming from the dural defect or the fistula? And could it conceivably be due to brain sagging and traction on veins around the cerebellum, or sort of mechanical distortion of venous structures around the brain that then bleed?
That's certainly possible. And early on, we kind of struggled with that. As you probably know, right? If you do a high volume lumbar puncture, or you put in a lumbar drain and you remove an excessive amount of spinal fluid, you can get, what we call a remote cerebellar hemorrhage. But that's usually not in the typical location of intratentorial superficial siderosis. It's not the superior cerebellar vermis, but it's more in the cerebellar hemisphere. I'm sorry, Dr. Rath? Dr. Beck?
I only can tell you what I've read in the last days in preparing on this talk. And one theory is that it's a kind of a cloaca, that the CSF turnaround is always passing the vermis. And this is just the place where the most CSF flows by. and it's just a place where the most iron and hemosiderin and ferritin is, is, is deposited. So that's at least what I've read in the papers, but Horst probably knows more.
Yeah, I think because the Bergman glia, the Purkinje cells, are extremely susceptible to brain iron, and maybe they suck the iron from below. We know the blood comes from below, and we have the most atrophy in the upper vermis where these cells are located. So that may be a reason. We do not really know the flow, normal CSF flow from downwards upwards, but I think the susceptibility of the Purkinje cells are the reason why there is so much atrophy. What we don't see is the layering on the 7 and 8 nerves. We call that the hearing difficulties. And we have if you have a higher amount of superficial siderosis, we also see it in the hippocampal layer, in the sulcus hippocampi. So we only see the tip of the iceberg, and we only see it in the cells that are extremely susceptible to that iron overload. And another question what I have, or the idea that comes to me, if we now facing the problem of superficial siderosis associated with lecanemab treatment for Alzheimer's disease, and that is related to the amyloid depositions of amyloid 42 and 40, would we have increased ferritin in this situation? Does anybody know that? Is that a difference in ferritin in infantile hemosiderosis compared to Alzheimer's disease-related CAA and CAA-related inflammation? Would be interesting to find out for the future. Just takes the CSF from below, which we do in patients looking for amyloid in Alzheimer's disease. So that is maybe we can difference or separate both entities via the ferritin in both patient groups. Okay.
I certainly don't have an answer for that. All right, everyone. Thank you for sticking around. Tomorrow we're going to start 10 minutes later than today, so you can sleep there.